Thank you so much for joining us tonight, everyone. I'm Teresa Blondin. I'm the manager of volunteers and community programs here at Bladder Cancer Canada. We're thrilled to be offering this presentation with Dr. Morales and Dr. Cote. I will now pass it over to Dr. Cote and Dr. Morales, who are live in Dr. Cote's lab at Queen's University. Thank you so much for being here.
Thank you, Teresa. Hello, everyone. Thank you so much for joining us tonight at our webinar, The History of BCG. I'm really thrilled for broadcasting this live from my lab here at the Queen's Cancer Research Institute. So as Teresa mentioned, I am an associate professor, a scientist working on bladder cancer and trying to find out why some patients respond so well to BCG immunotherapy and some don't, and also trying to develop newer combination treatments that we can add on to the current treatment regimens. So as you all know, BCG is the most common treatment for the non-muscle invasive bladder cancer. And it has indeed saved so many lives and bladders. And we are really honored to have Dr. Alvaro Morales here with us, who doesn't need much of an introduction because he was the one who started actually treating bladder cancer patients with BCG immunotherapy many, many years ago. In fact, almost 50 years ago, it was the first patient here at Queen's University who got BCG immunotherapy from Dr. Alvaro Morales. I just wanted to mention that all the questions for tonight's webinar were submitted already to Dr. Morales in advance, and we don't believe that there will be any time for additional questions. However, we are quite confident that the questions submitted are very comprehensive, and we are sure we all will learn a lot here tonight from Dr. Morales. Huge thanks to Shasha Boshoff, who's running the tech here in the lab tonight. And now I just want to introduce Dr. Morales, a little bit about Dr. Morales. Dr. Morales completed his undergraduate training at the University Javeriana in Colombia, and I'm sure I'm pronouncing it incorrectly. His surgical training in Washington, D.C. and Boston, and his urological training here at Queen's University and at the National Institute of Health in Bethesda. He also received the medal from the Cancer Research Institute of New York and the Order of Canada, which is the highest honor here in Canada. Thank you, Dr. Morales. Thank you so much. And I'm just going to begin the webinar with some of the questions that we all have. When I entered the field of bladder cancer, the question to me was given by a urologist here at Queen's University, Dr. Robert Siemens, and he said, let's find some biomarkers that can tell us about which patients can respond well and which patients are going to not respond so well. So, and since then, the question about what is BCG, how BCG came into existence in the treatment of bladder cancer has been in conversations for the last 6-7 years. I talk to students, we come up with the same introduction. How did Dr. Morales brought BCG into bladder cancer? And we really want to hear it from you. Please tell us about BCG and what made you think to give BCG to a bladder cancer patient?
Well, I'll try to go back 50 years. But first of all, thank you very much to you for the invitation and for the Bladder Cancer Canada for asking me to go back into the good old days when we were young and dynamic and enthusiastic and ready to conquer the world. The long story is that BCG has been available for over 100 years. It was developed by Calmette and Guerin, used to work at the Pasteur Institute in Lille, and essentially for the prevention of tuberculosis, which was a very bad disease in those days. And through many ups and downs and tragedies and successes, it became established and it was used as a vaccine for TB in large parts, many parts of the world. Going to the personal situation of BCG in cancer, you have to go back to the 1960s. At that time, there was chemotherapy became the dominant form of non-surgical treatment for cancer early in the 20th century, and immunotherapy was not even considered. There was the college vaccine, which was partially successful, but it was never approved. And so nobody really was considering immunotherapy at that time. But then by the 1960s, a group of researchers in Europe and in North America became interested on the use of BCG. And a lot of work was done, particularly at the National Institutes of Health in Bethesda, and working with in different kinds of cancers in animals. And with BCG, they established the parameters for successful BCG therapy. Clinicians, we tend not to understand basic science. Sometimes we work with you, you tell us things and we say, no, that's not the way it should be. This is this way. And of course, the work of very giants of immunology in those days, Dr. Sebar and Dr. Rapp at the National Cancer Institute, working with mice and syngeneic tumors, determined the parameters for how BCG could be successful. And they say, well, you have to have a relatively small tumor load. And I want to emphasize for the audience that BCG is effective only in early bladder cancer. Once the tumor has extended beyond the lining of the bladder, it's not efficacious. So going back, they were saying you have to have a small tumor load. You have to have a tumor that is antigenic, that tells the body, here I am, come and attack me if you can. The vaccine, the BCG had to be alive. So remember, we are dealing with a live bacteria. Kill BCG or fragments of BCG or pieces of BCG or irradiated BCG has been proven that it doesn't work. They also determined that you require a sufficient amount of live bacteria, and that has been one of the problems that different labs produce vaccines with a lot of live bacteria. Others, they don't contain as many. And I think these were essentially the basic parameters. But then clinicians, we started using BCG for metastatic lung cancer, gastric. There were people injecting it for melanomas. Actually, melanoma was partially successful. Oh, and the last thing I forgot to mention, the direct contact between the BCG and the tumor. Now, honestly, I have received a lot of accolades and honors, but it doesn't take a genius to get those 5 parameters that they have decided the scientists at NIH and said, bladder cancer is the ideal tumor. It's a small tumor load. You can put the BCG directly into the bladder. You can get a large amount of BCG. It's relatively well tolerated. And the patients are in relatively intact or have an intact immune system. I was fortunate enough, 50 years ago, I was a young faculty member here at Queens. I had a head of department, Dr. Bruce, and he has created this environment that he facilitated people to do research and inquiry and ask questions and things like that. And of course, I was always asking questions and wondering about this. I would like to diverge a little bit and say that in those days, doing research was easy from the regulations point of view. The ethics were, you just presented an idea, presented a plan, and without much problem, you was given the, okay, why don't you try? So the next thing that happened is that we applied for a grant to the Medical Research Council that doesn't exist anymore. I believe it disappeared. And this is the anecdote I would like to mention, is that our application was rejected. And the sentence I remember most clearly was by one of the reviewers who said, this BCG is a throwback of the Stone Age of immunology. This is 1969, 1970. Sure, it was, at that time, it was 50 years since Calmette and Grant had postulated the BCG. However, there was another small group called the Ontario Cancer Treatment and Research Foundation, and they gave us a small amount of money that allow us to initiate the studies. We didn't have enough even to buy the BCG, which was very cheap in those days. But the Frappier Institute in Montreal offered to supply us the BCG for free.
Mhm.
So we have all these animal studies. We have patients here at Kingston General Hospital who have bladder cancer. And I don't have to tell the audience that bladder cancer is probably one of the most expensive cancers to treat because the follow-up is for life. You have to keep checking because of this tendency to come back. So our idea at the very beginning was, why don't we study those who have already shown that after the initial tumor was treated successfully, what about if we give them BCG and see if we can decrease the amount of recurrence, the reappearance of these tumors? And these were patients who have been diagnosed and they have 3 or 4 recurrences and they were coming every 3 months and they have the tumors fulgurated or the tumors were removed. There was a drug called thiotepa in those days, I don't think it's used anymore, that had a moderate, very modest activity. And then to our surprise, in a very small number of patients, we found that they really responded, that the number of recurrences of the tumors was significant in a very small number. So we say, let's send the paper to the Journal of Urology. So we sent the paper to the Journal of Urology. Surprise, surprise, it was accepted with a great deal of skepticism. I read it now and they asked for an editorial comment to the professor of urology at Harvard. And he wrote a very interesting editorial comment saying that, boy, these guys had guts to do this, to put a live bacteria into the bladder. Essentially, he said, I don't believe them.
So they did not believe the data,
yeah, he said,
the
well,
response that you observed.
yeah, it has been used in other tumors and it hasn't responded. Why in bladder cancer? Obviously, was not aware of the studies done at NIH. We were so lucky that somebody, to this day, I have no idea whom, at NIH thought that the idea was very intriguing. And they said, well, what about if we run 2 studies that have to be done not by us here at Queens, have to be independent studies with large number of patients, fully supported with the large budget that National Institute of Health has. And sure enough, they have 2 studies. One was run in New York at the Sloan Kettering Memorial, and the other one was the Southwestern Oncology Group.
Dr. Morales, if I may interrupt you briefly, do you mind telling our audience how you established the initial dosage of BCG for the induction phase of the treatment?
Well, that's an urban myth. You know, people say you use 6 doses because Frappier was sending in those days, the BCG was lyophilized. It had to be reconstituted to be administered to the patients. And we knew that BCG has been commonly used in Europe for prevention of tuberculosis. I think in India has been for decades. Certainly in South America, when I was a kid, I got the PPD and the BCG and whatever, but not in English Canada. I think in Quebec, BCG was quite popular in children, young kids. So we felt that the majority of people from Ontario has not been exposed to BCG. And in order to develop the first reaction should require at least 3 weeks.
Mhm.
And we said, but that's for people who have been exposed to BCG. So I said, it has to be probably 4. Then he said, there are 6. 5 may be better. And we are not going to throw the 6th one in the garbage. So we're going to use it. We decided for weekly intervals for 6 weeks because we noticed that patients develop side effects. At that time, we were administering the BCG in the bladder, but also by scarification in the arm. And after 5 or 6 days, the symptoms of bladder frequency and irritation seemed to decrease. They may not disappear, but they were getting better. And the reaction in the skin was beginning to, the flare was beginning to decrease. So we decided on the 6 weeks, on the basis of, it was known at that time about the immune response, the delayed hypersensitivity reactions that people develop after 4 or 5 weeks, and the fact that Frappier, thanks God, delivered this in 6 ampules. The reason I say thanks God is because studies later on have tried to modify the original protocol, and it has been found again and again that 6 weeks for the induction is the ideal treatment.
Thanks. I think that's a great explanation, because a number of people from the scientific and non-scientific field, they do have this question why we give 6 and how that existence of 6 doses came.
There was some basis on clinical knowledge, a lot of basic science information, and the serendipitous fact that Frappier produced that BCG in ampules of 6 ampules per package instead of 5, because 5 was
5
found.
would work. Yeah.
We knew it has to be more than 4, but 6,
Right.
well, was good luck.
That was good luck for sure. And it has remained good luck for years. As we know, many patients do benefit from this treatment. So please tell us how it was then validated. You were telling about how the bigger trial was run in the United States.
Well, and again, this is another anecdote. I don't know how much more time we have, but it's probably one of the most scary and the great happiness in my life, that the National Cancer Institute run the 2 studies. And then the studies, it were well over 600 pages. It was a very large, well-documented study, properly run by very reputable medical centers. And I remember clearly the results. They say, okay, these trials have been finalized, the statisticians have investigated, but everything has now been under lock, and nobody can tell if they work or not. And they call a meeting at NIH in Bethesda. And I clearly remember going to that meeting and really scared, because this was going to say, these guys are a bunch of liars. Or they may say, this turned out.
It just worked in a small group of patients.
No, ours was such a small group of patients. Don Lamb was at the breakfast. He was sitting there in the cafeteria, and I look at him, and he just said, and this, excuse me, an hour later, he was giving the results. He just did exactly what we have documented in our small group of patients. That to me proves that if you follow your patients well and follow the criteria, you can prove many things without humongous studies.
But that must be quite a moment when you felt.
Oh, it was such a relief. Well, no, it was the relief. I was really scared.
Validation. It's always important to have that reproducibility and validation in science. I think one of the questions that was sent was, how does BCG work in fighting cancer?
I was going to ask you that question.
I think that question has remained for 50 years, although based on my readings and based on the work, tremendous efforts that have been put in this area of research to understand what is the mechanism and what is the mode. So when it comes to the mechanism, what is happening inside the cell when the BCG is taken in? and how the entire patient's immune response is kind of working together to keep the cancer under control from progressing or recurring back. I think that those questions have remained for the last 40, 50 years, as we say. But we do know a lot about how it works now. But still, I don't think we still have the clear answer, steps 1 to 10, about how BCG is actually. We know that it is stimulating the immune response. We know these patients are older and they need a boost. So repeated BCG is probably giving that boost in stimulating the immune response and keeping the cancer cells not regrow or progress into muscle invasive stage. So in terms of the immune army, because it's a mucosal immune system, we have the macrophages, we have different cells of the immune system that are placed on our body surfaces that are exposed to the environment, or let's say in the case of bladder, the urine, the bacteria there. So immune system works differently at different surfaces. As we learned from COVID, the immune system at the nasal or respiratory tract is so different. Similarly, for the gut, the gut microbes are so different, and how the gut immune system responds. So we do understand a lot about how BCG works, but there are still so many unanswered questions, and I don't think there is any clear answer about how it's actually working. We do know some antigen presenting cells take up BCG, they prime the long-lasting adaptive immune branch of immune cells that comes and fights the cancer cells that remain. So BCG is basically being given at a time when the tumor has been removed, and it's basically mopping up the residual cancer cells. And repeated BCG keeps the immune system strong, and that's how we kind of restrict tumor regrowing. So that's what I guess is known about the mode of action of BCG, but we don't still have a clear understanding of the exact mode of action in a patient. And there are so many other factors like patient age, patient gender that also influence how BCG is working. Plus, it comes as a lyophilized preparation. The live bacteria that are actually getting delivered and absorbed by the bladder mucosa. That's also another big factor in terms of how BCG, plus the commercial various strains and all. So there's no clear answer to that, but still we do know a lot about how BCG works. Now, another question that has been sent is, how is it made? So do you want to tell anything from those days to today? Has anything changed in how BCG is made?
Well, again, I have no expertise whatsoever in this, but I understand that BCG is relatively easy to make. It's just a bacteria that you grow in a special medium, and you grow them, and there you have your BCG. Years ago, decades ago, there was almost every country produced their own BCG for the purpose of vaccination for TB. So they all derive from the original BCG that came from France. But through all these transfers and cultures and recultures, they changed, the BCG changed in many respects. And some of them became very effective and became very popular, others were less effective. So I'm not evading the question. I'm simply saying, I don't know the answer how it is made, but I realize that over time, the regulations for the growth and production of biologicals is so much more complicated now, which I don't know if it leads up to, I think there is a question of why there was or there is a shortage of BCG. And part of it is because of the difficulty to produce a reliable biological. Is very different from producing a chemical. Exactly. Like ibuprofen. You can produce millions of those tablets. Mm-hmm. Apparently there is a shortage for children, but a biological is much more complicated. You have to, I don't know, it takes weeks to grow the bacteria in batches, and you have to make sure it's pure, not contaminated, blah, blah, is complicated. That part is complicated. And the regulatory agencies are keeping a very close eye on the production.
So there's I think the problem is there is more demand, but the supply is less, which is a main factor that is underlying the shortage. But the supply that we get in Canada is from Merck, that is supplying the Thai strain of BCG. And that will bring into another question. But recently, Canada has approved the use of Verity BCG, which is basically the Russian strain of BCG that is manufactured at Serum Institute of India, which is approved for high-grade tumors with no concomitant CIS.
This is, which one is it?
Verity strain, Verity BCG. So Verity is the company that is kind of bringing it to Canada.
This is not
but
the
it's
Russian
strain. It is.
Oh, it's a Russian strain.
It's the Russian strain. So talking about the strains, there is a question about how, why there are so many strains of BCG. No.
Well, as I was saying before, it's not difficult to produce BCG. It's difficult to produce high quality BCG for the purpose of treating bladder cancer. In those days, Canada, they have two sources, Montreal and Toronto, Connaught and Frappier. But it was being produced in the US. I remember Argentina, every country was producing them, India. And some of them were better than, there was Glaxo one that produced a lot of side effects and very poor efficacy. So it disappeared very quickly from the armamentario, that particular BCG for bladder cancer.
Yeah. So the question about strains, I would just like to add a little bit about the strains. When BCG was initially made at the Pasteur Institute, those days the lyophilization techniques were not really well established, and the bacteria was supplied as a live culture to various countries and labs that needed. And as different laboratories started growing this BCG, the bacteria obviously adapted to the culture conditions that are obviously were variable, and you can never have identical, because it's, as Dr. Morales said, it's not a chemical, it's a live bacteria. So that variation introduced a little bit of variation in the strains, how they adapted and how they survived. And in that process, some of the immunogenic epitopes, or some of the immunogenic regions that would cause a different degree or level of immune response, those were introduced, those changes were introduced because of that distribution, and which is why we have various strains of BCG. And in fact, there are some trials running in the United States almost to completion, where they are testing two different strains, the Japanese and the Thai strain, to see if there are strain differences. And obviously, it's very difficult to conduct a trial in a huge population to really know, because of the so many factors: the tumor stage, the grade, the host, your own immune response, if you have autoimmunity, if you have urinary tract infections, or if you are an older person. So all these factors do affect. And it's really difficult in a human scenario to kind of test how these strains are different in terms of restricting tumor growth. The next question, Dr. Morales, I think it's for you. What is a treatment protocol, and how are treatment protocols developed?
Yeah, well, it depends. As I mentioned earlier, the treatment protocols at that time were very easy to develop. You establish certain criteria and you just follow. The ethics review were not difficult. You have to make sure that what you were using was safe. That was the most important thing. Over time, things progress in which you have to demonstrate not only that there were good scientific basis for the agent that you were testing, that you were evaluating, there was a population for this, and that whatever you were trying to investigate, it was going to be an improvement, a better agent or a better solution to a problem. Then after that, then you have to determine a population to make sure that the results were proven to be accurate and reliable. You have to bring the experts in different fields. For instance, if we were to develop a protocol for a new treatment for bladder cancer, most likely before it will ever come to consideration for approval by the regulatory agencies, you will have to have comparative agent, which was one of the problems with BCG at one point, was that a lot of people tried to develop better compounds than BCG, particularly for that population who fell to one or two courses or that were called the BCG non-responders. But then what do you use for a comparison if they have already used BCG and BCG is relatively effective? It's fairly effective. So the protocol has to take all these things into consideration, the basis of the basic sciences studies, the clinical experiences, ethic regulations are extremely important, the bioethics of all these. Eventually you have to bring the statisticians too, who are going to tell you how many people have to enter the study, have to be distributed, what you anticipate is going to be the response to get a successful, not just approval, but even acceptance by a medical journal.
Yes, absolutely. And again, multiple centers globally have to reproduce that data. There was a question about why it took almost 20 years, seems to be a long time, to get approval from Health Canada to use BCG in patients.
Let me go back a little bit in that regard, because as I mentioned, the study that it was when we had that meeting at NIH and the results of these two large studies were presented that they appeared to be quite successful. There was a lot of pressure by American urologists. The American Urological Association, I wrote letters at their behest. They were putting a lot of pressure on the FDA for approval of BCG. I don't remember clearly, but I don't think the Canadian Urological Association had the same degree of interest or input in having it approved. I don't know if that's the only reason. Health Canada tends to be a little bit slower than the FDA, which are the only two that I have had any dealings with. But I don't know why it took so long for a Canadian contribution to be approved here when it was approved in Europe and the US already.
Well, it's the gold standard treatment, and I don't think anything has been able to replace.
But we hope that something else will come.
Exactly. I think that's what is the next question. What are some of the alternative treatments that are coming up, or what is your opinion on?
Well, I'm going to give you another one of my anecdotes. I from the very beginning, we thought that BCG, it works very well. I have to mention to you that we were talking essentially before about the papillary type of tumors. But there is another type of early bladder cancer, is the carcinoma in situ, which is the flat carcinoma. It's not like carcinoma in situ of the uterus that is very easy to treat and with great success locally. Carcinoma in situ of the bladder is a nasty disease. Hubert Humphrey had carcinoma in situ in the 1960s. He was a candidate for American presidency. And they fiddled because he was in a campaign, and they fiddled with this and fiddled with that, and eventually it killed him. BCG was not available. Well, it was available, but we didn't know that it was so effective. We did a study on carcinoma in situ, again, the very first one, and it's more successful than for the papillary tumors. 70% of patients with carcinoma in situ respond to BCG. But I was diverging from what you were asking. What about other treatments? We felt that indeed, even 70%, which is very high, still leaves at 30% who are not responders.
Absolutely.
For the papillary tumors, there are about 40% that are not responders. We were talking about the 6 weeks, which was the induction. But after that, again, the Southeastern Oncology Group showed that after the induction, if you continue treatment for a year, and other people were trying, let's try it for 3 more months. And what about 6 more months? Because the tendency of these tumors to come back. And the Southeastern Oncology Group decided it's going to be 3 years, reduced doses. But the majority of patients were not able to tolerate it. So BCG has 2 major drawbacks. One, is not 100% successful. You know, it will be wonderful to have something that everybody responds. So anything between 40 to 70% leaves still 60 to 30% that are non-responders. The second one is the side effects. There are a lot of, not just the local side effects, the blood in the urine, the bladder irritation, the malaise, but there are systemic things. And over the years, I see almost every week a paper report of some granulomatous BCG lesions in the brain and the lungs, everywhere. We were working here in the early 1980s on something different. And do we have time to tell the story of
Yes,
the
absolutely.
MCNA?
We have.
Okay, well, the story of the MCNA to me is very interesting. It's a company here in Ontario, actually in Belleville. Yeah, in Belleville. I'm confused because they have offices and labs in Montreal too. Anyway, they have come with a preparation. It was a veterinary preparation with a different mycobacterium, not the Mycobacterium tuberculosis, which is a pathogen. It can kill people. But this is a different mycobacteria called Mycobacterium flei, which is a saprophyte that cannot produce a disease. It's everywhere you find it in nature.
It happens to be a close cousin of BCG.
That's right, very close cousin, but it's not BCG. In addition, this company had were able to extract. And at the beginning, when I first started working with them, they were so close here from Kingston to Belleville. And I said, why don't you move to Kingston and work at Queens? Had the great advantage of we were not using the bacterium. It was the DNA. Eventually, that's what it was. It was the DNA of this bacteria, which it gave an enormous improvement on the safety profile. And we run clinical trials, and we were able to go all the way up to the FDA. Unfortunately, in those days, the FDA regulations were even more strict than now. And at that time, they felt that because it was not a double-blind controlled study, again, we had the great difficulty compared with what? We were looking only patients who have already failed BCG, which remains the best treatment. So we didn't have a good comparative. There was mitomycin and there were other compounds that were not as good. So the FDA asked for a controlled randomized study. That was going to cost millions of dollars. The company couldn't do it. They try, and eventually the whole thing disappears. So it's one of those regrets I have, because I think it has enormous potential for safety, and the response rates were relatively good in this terrible group of people. in which BCG has failed. To this day, we see reports almost every month. There's something, a combination of this or a new chemotherapeutic agent, and they don't pan out. I have been seeing this for the last 50 years, and I am as amazed as you are that in those 50 years, nothing has come better from this throwback of the Stone Age of tumor immunology.
Well, I think I would disagree a little bit on that one now, because there's a lot of excitement with the newer treatments that are coming up in the BCG non-responsive space as well as the BCG naive space. So there is these newer immune modulating treatments that can kind of release the brakes or kind of take care of the exhaustion. So our immune system can only fight to a certain extent. After that, it gets tired. So there have been newer treatments called immune checkpoint inhibitors that are in under several trials.
Oh, I completely
And
agree with you.
those are the ones that are coming, and
Yeah.
and there's a little bit of excitement with those. Although we, as you said, it's initial excitement, we still have to see some really meaningful outcomes. But there are newer oncolytic virus-based treatments, adenoviral vector delivery.
Yeah, the checkpoint inhibitors are
Yes.
the ones that have generated a
A
lot of excitement,
Exactly,
and
you're right,
everybody
yeah.
thinks that's going to be the
That is,
key.
yeah, I completely agree with you, Dr. On that is only a little bit of the story here in terms of what we will achieve in terms of complete response. We still are waiting to see that wonder drug or the wonder combination that will work best and in an individualized manner. So we really need information from the tumors as biomarkers from those tumors that can tell us which patient will benefit and which patient may not benefit as much. Plus, we also, I guess we also need to run a lot of these combination trials, which are kind of underway in terms of the newer treatments, as I was mentioning, oncolytic viruses or immune checkpoint inhibitors, or even the newer recombinant BCG, VPM 1002 or MTB-WAC. These are newer. But again, I think we still have to wait maybe another 5 to 10 years to see the real outcomes of all
Yeah,
these
the
trials.
genetically modified BCG, I found it very exciting because
Exactly.
I think they are already in phase 2 trials.
Phase 2
They are
entry.
quite
Yes.
advanced, and the response seemed to be good in patients who have failed regular BCG, which
Absolutely. Yeah.
that is the population of bladder cancer that is the most disturbing, because the only option for these people is a cystectomy,
Cystectomy.
which is not a very pleasant
Mhm.
option. And if we can avoid it, that will be the ideal situation. And there are other things to remember, and it's the fact that bladder cancer is not the most common cancer. It is not very common. It's mostly in the older population. It's unusual to see bladder cancer in the younger population. So the number of patients that can participate in the studies is not very large, and they are very difficult to get. We have that experience when we were trying to recruit patients for the MCNA studies, is that the majority don't require any more treatment after the surgeon has dealt with the tumors, but a good number of them. The ones who have recurrences are very few and far between, and then they respond to BCG. So there's not a heck of a lot of population left there to investigate these new drugs and compounds. It requires large multi-center studies with a lot of money, a lot of effort. I don't envy the young researchers like you because it's tougher to
Well,
get them now.
there's been a lot of efforts, I guess, to develop something new.
Mhm.
I think the information is mainly lying I mean, in my personal opinion, you can derive a lot of information from the patient itself in terms of patient age, the patient gender, the patient tumor itself, and the immunologic competence of all these three together, and what are certain snapshots or signature events that we can identify from those tumors. in order to, plus then how it comes, we have something that is that can be used as a monitoring approach where which can be applied when the patient is undergoing the treatment, actual treatment. And again, but as you said, it needs large number of patients, large number of trials, and there are so many differences.
I would like to bring a point to when you said to know the patient's immunocompetence. I don't think it's possible to assess the immunocompetence of everyday clinic and patients. When we started the clinical trials on BCG, as I mentioned before, we used to administer 5 milligrams by scarification. And there were two purposes. We thought that it will increase the immune response. But number two, it will tell us if the patient responded or not. And I don't know if we ever published any information, and I don't recall the data. But patients who have no response, you give the BCG, and next week they come and there is nothing there, and 2 weeks there is nothing there, and 3 weeks is nothing there. You think same thing is happening in the bladder. There is no response. It was very simple, but these large American trials said, no, that's not necessary. I disagree with them.
You think that should be brought in back again?
Well, it's an inconvenience to the patient, but maybe not do it weekly as we were doing it, but do it at 3 weeks and then at 6 weeks. And if the patient has a good response in the skin, I keep pointing to my arm, you imagine that the same sort of response, the macrophages, the dendritic cells, all these cells and cytokines are working in the bladder the same way they are working in the skin here. Mind you, this is normal tissue.
I think that should be revisited.
Let's hope so.
Measuring host immune competence before we actually before we actually assess the response. So Al, before any other anecdotes you would like to tell?
Not for the time being.
Something about the letter you received from the person who discovered who.
Oh, yes. Well, last year we published a paper with Don Lambon, the history of all these things that happen. And when I was digging on my papers, I found it may have been around 1981. I was meeting someplace, I think it was in the Netherlands, and there were a whole bunch of, a large group of researchers in bladder cancer. And there was a professor, I forgot his name. After 50 years, I'm not 50 anymore. No, it was, he was a urologist at one of the hospitals in Paris. And he told me, Alvaro, I bring you greetings from a lady in Paris. And so people say, ooh, ooh. And so he told me it was the daughter of Professor Guerin. And she wrote me a letter, which of course I frame it because it was such a coincidence. This is the daughter of the person, because he's the one who really developed BCG. Yeah. He was the guy in the lab doing the transfer every 2 months or something, doing the cultures and subcultures.
And what a coincidence that the daughter.
Yes, and then she says in the letter that she developed bladder cancer and she was treated with BCG. 2 years follow-up. Now, no more recurrences. So she was very grateful. She was I assume an old lady because her father had died in the 1940s, I think. I'm not sure. But anyway, it was a very interesting coincidence that the daughter benefited from what her father had created. That was really amazing.
Created for tuberculosis, and she gets for the other application, the most successful. I think we are close to finishing the webinar, and anything else that you would like to tell our audience, Dr. Morales, in terms of the newer treatments that are coming up for BCG? And
well, we have to wait and see. There are so many things that are being announced and advertised, and we have to keep our fingers crossed because it has to be better treatment than a cystectomy, and it has to be a better treatment than BCG. Of course, we are very grateful that these have worked and it has worked for 50 years, but it's not a panacea. We want something that is easy to administer, that has a response rate close to 100%, and it doesn't have any side effects. Let's wait and see. And I want to thank the Cancer Canada. I think you are doing a tremendous work because it's not a popular cancer. You know, everybody knows breast cancer. For men, it's prostate cancer and lung and stomach, but bladder,
But I think that we need to prepare ourselves, given the aging population. We have hit 8 billion a couple of weeks ago, and it is estimated the number of cases. Incidence will rise. Mortality may not, because we have improved our screening, prevention, and treatment methodologies, approaches. But
the great advantage of bladder cancer is that, at least for men, is that the manifestations are early. The blood in the urine and the bladder irritability. It's hard to miss it when you are a man, not to see the blood in the urine. A woman may have more difficulty, and it's very alarming. So they go to see their doctor, first to a urologist, and they are treated early. So that's the time to get whatever, early treatment.
Early treatment, exactly. This brings us to almost the end of the webinar. Before closing, Dr. Morales, thank you so much for joining us. As we are almost 50 years, as you said, you never kept the records because you did not imagine the success of BCG in bladder cancer.
And
but
I never expected
it's the most
it.
successful immunotherapy for cancer. I think it's pretty well documented.
For
A
solid
lot of
tumor.
patients respond. And we have seen a lot of benefits. Of course, we need to bring that number up with newer combinations and treatments. But thank you so much for joining us today for this webinar. And it was great to have you here and listen to the story directly from you. So before closing, if you have enjoyed this session today, please check out our other upcoming webinars on our website, on BCC website. So I'm speaking on behalf of BCC. Our next being an information session on blue light cystoscopy in February. I'm very excited for this one too. I would like to attend this one as well. If you have additional comments or questions, please call us at call BCC. I feel like I'm part of BCC now, as actually I am in many ways, at 1-866-674-8889. or email info@bladdercancercanada.org. So thank you so much. Thank you to Michelle and Sasha, who are standing right behind the camera here, and Teresa managing the whole event, and Dr. Morales, and Priyanka, my PhD student, who's also here helping us out organizing. So thank you so much, everyone. It was a pleasure to have Dr. Morales.
Pleasure having mine.
And hope you all have a good evening.